And we have the pleasure, I have the pleasure really, to invite our friend and distinguished city operator, let's say, Dr. Sianos, Professor Sianos, George, please, and thanks for coming with to discuss this undiscussable from physiological aspect lesions.
First of all, it's my very great pleasure to be here over the years, and the task is, of course, to talk about something completely different that it has been said. It was a really amazing and highly educational day about a field that it is evolving by experts, and over. Sorry. What do you need?
Power from the laptop.
It's over there. But I'm okay with the power. I don't need power. As far as projecting, it's fully powered. So I decided, instead of giving a lecture in a day that it was full of concepts and quite new things, to make it your life a little bit enjoyable. So I decided that I will present you a live case in box. I think that that will not deviate a lot from the purpose, and it will bring us a little bit more to more customary aspects of what we're used to do. So I'm going to show you a CTO of the LAD in a patient that was 41 years old. He had a heart attack in our hospital 15 days ago, and an RCA PCI was done as a primary PCI, and at that time an occlusion of the LAD was noted. So the patient was programmed to have a recanalization of the LAD after the primary PCI VRCA. You see here the first catheterization, the diagnostic angiogram that shows the ACS occlusion of the right coronary artery. This is the result after the primary angioplasty with stemplantation in the mid and the proximal RCA. And here is the intervention for the right coronary. What you see here is the setup is, of course, completely different. You see the dual access, one guiding into the right coronary artery. The procedure is radial femoral, as you can appreciate from both pictures, and a 7 French EBU into the left system and the right coronary artery injection with an AL1. What you can appreciate there is a flash occlusion with ambiguous cup. There is a big septal branch just to the occlusion, and a subtotally occluded big diagonal branch. So we're talking about new developments in CTO PCI, but the fundamentals are even more important than any kind of an thing that it has to be do with technology development in 2025. So double injection, basic things. What you see here is the imaging, because the proximal cup was not well defined. So we put an IVUS catheter into the septal branch. That's also another aspect. The imaging is extremely useful. And you see here the wire into the diagonal branch. I will elaborate a little bit more in that. So we're looking with the IVUS. We push more, and you see here at that point that this is the occlusion of the LAD. You marker that with your catheter into the angiographic image, and you have a little bit of a feeling of where you have to go. So that's part of the exploration about the strategy, which is very important into the planning of a CTO. Here is the film. We give a little bit of contrast. We see where the transducer is, and that gives us an idea where we should puncture the proximal cup. So from the other side, as part of the procedural planning, in order to make decisions about what's going to be your primary approach, you see that there was a tip injection in order to reserve some contrast through a microcatheter, which was the the fine cross because it's the highest, it's the biggest lumen microcatheter. And based on the accessibility of the collateral circulation, we decided to go primarily retrograde, as you can appreciate here. And it paid off. You saw how the crossing of the axion black wire was in the collateral circulation. And what is really nice in this case, there is a wire in the proximal cap, and there is a wire just from the distal cap, and you see what is the length, plus also the fact that in this high-quality image, there was an indication of the calcification that was existing into the distal cap. So I'm presenting this case because of the evolution. Many of the things that you face in everyday life, we face them in this case. And one of them was after we made the decision about what the strategy might be, we started facing also the consequences of that. You saw that the fine cross failed to cross this collateral, and we know that with septal surfing, we face that in a higher level compared to a non-septal surfing of wire crossing but no microcatheter crossing. It can be around 7% of the total cases. One first reaction to do is to exchange your microcatheter, and you can appreciate here where you took a different microcatheter that can provide the rotational force propagation, just like the turnpike LP. The structure of the microcatheter is as such. But you see that this microcatheter, despite all of our efforts, also failed to cross the occlusion. In different projection, a generous approach, you see my struggling there, trying to push the microcatheter to go, and despite optimal support with the guiding catheter extension, it doesn't really go. So facing that, we decided that we are going to move in an antegrade part, and we used the dual lumen microcatheter as here, the Sasuke. You can appreciate it here. And then trying to antegrade probe. You see here how the microcatheter is, the tip of that, and then how the wire exits a little bit proximal from the marker through the second lumen. And we are approaching now having an image of where the occlusion might be, plus the marker of the retrograde wire. And the characteristics of the wire were shown over there, but what you see is that we are definitely to the right direction. We're not 100% sure that we punctured, but you see the calcification there, and you see that the distance between the proximal and distal wire are very close, but far enough to set a failure mode. So we exchanged that to Gladius wire, which is the polymeric wire that also failed after the Gaia 3. And after shifting from retrograde to antegrade, we shifted back to the retrograde, and we took one of the best-in-class wires, 1 millimeter. And the purpose is, like the old good times, to dilate the collaterals in order to facilitate the microcatheter crossing, as far as our attempts for antegrade probing failed. And you see here, it's also a laborious process. We're inflating up to the point that it is accessible from the wire. In this case, it was not completely possible to advance this 1.0 balloon all the way through the collateral. You see here the dilatation. This was done from the very beginning back in 2005 to dilate the septal collaterals because there were no microcatheters at that time. And you see that it requires an effort, which is substantial. And we tried again with a turnpike LP microcatheter. But again, this failed. And on that respect, the next step to do, you see how we do. This is a catheter that makes a trapping. And we reinsert now a different microcatheter. This marker here is a wire because when you want to move out devices that they are 150 meters long, then you have to trap it in order to remove them over a wire that is 180. So the third microcatheter in the way. So all of these are showing the evolutions of how things are going on. It's a contemporary practice. How do you react to a problem? And then you see that a fresh microcatheter, a little bit different design microcatheter, that the coat, it might have not been peeled, actually engages the balloon dilatation facilitated septal crossing. We make here a tip injection, which is also critical. You see also the calcification here. And the message that we see from this picture is that also the distal cap is also blunt in the direction of another big septal branch. But at the bottom line, we have both the setup of antegrade and retrograde approaches. We know where we have to go. And now from the retrograde, we do exactly the same approach, wire-based approach with escalation. We know that the lesion is calcified. And in that respect, we took a wire of around 4.5 grams, which is still in the intermediate range. You see that there is a lot of repetition in the wire, and this is part of the process of, let's say, get acquainted of the wire probing and knowing that how have to use the wire best. You see that the technology, at least in the hardware of PCI, has evolved, and the simple wire has now a microcone tip, dual core tapering with a snorkel, X-Tran technology. It's not part of this presentation, but as you saw that in the physiology, there are huge advancements. The same way it happens also into the hardware part of interventional cardiology. So as far as you come to the points of, let's say, of documenting of what is the best approach to do in order to document what is the best outcomes as of this great session that we have today, the same thing happens of really improving when you have a very clear documentation, and the CTO is part that physiology probably is the less necessary. Anyway, you see how it worked, and over a certain period of time, the wire that we fought for 2, 3, 4 minutes engaged the distal cap in a way that was sensible, and afterwards it was propagated, as you can appreciate here, and crossed the occlusion retrogradely, and we reached the aorta. And you see here in this spot the difference between the successive failures. So the antegrade wire went up to a right point, but then afterwards it deviated and then it was subintimally. This wire, the retrograde wire, entered the antegrade microcatheter. There was a balloon trapping to support the lesion crossing with the microcatheter. Microcatheter has been advanced retrogradely into the antegrade catheter, as you can appreciate here. And after this process, a wire is externalized. You will see now gradually that the microcatheter will be pushed. Sometimes you find resistance from the microcatheter into getting into the antegrade guiding, but finally it happens, as you can appreciate there. What we did as another of the evolution, you see that there is a wire in the sinus that we inserted. Here is the microcatheter. And the purpose of this is to protect the guiding of really engaging deeply in the left main. So it's essentially you're protecting the left main. So you see some more details because the topic that was given by Dr. Gelef is to address what is contemporary, what is breakthrough. CTO has reached a maturity, but and there are no major breakthroughs on that. But what you have to do is that you have to improve the small things of it that are really, they are improving the effectiveness of these devices, less contrast, less radiation. One other specific thing, and that's why I'm presenting you this case, is that despite the fact that we externalize the wire, we still don't have a wire in the distal LAD, so the procedure is far from success. So we dilate the lesion, so there is no intervention that can be concluded with the setup that we have up to this point. The success is not guaranteed. Of course, the CTO part has been crossed, but a stent cannot be deployed adequately to finish the intervention because there is no wire in the distal LAD. We have a wire only from the mid to proximal LAD. And what you see here, we predilated the lesion, and that's another step to do. You're inserting again the dual lumen microcatheter, and you take a routine wire, and now the wire is crossing into the distal part of the LAD, and the procedure becomes, let's say, more predictable anymore of going a success. So you saw all these continuous steps of procedural planning, antegrade, retrograde, puncture of the proximal cap, puncture of the distal cap, and all of the details of trapping, externalizations that are necessary in this kind of procedures. And I'm coming to an end because the program is going to be extremely interesting for the next microvascular assessment with physiology. We did the predilatation. This is the result after the predilatation. The branch was also predilated. And not to make the long story short, 2 stents were implanted. And this is the final outcome with a crossover over the diagonal branch, which is sizable, that actually didn't require any further intervention. And these are the final pictures. And more or less, this is what we call today contemporary CTO PCI. The case didn't include any kind of all the evolution of what happens with the antegrade dissection reentry techniques, but I think it represents a little bit of where we are standing. There is still some material evolution, but the rest is more or less became like standard practice in the field.
Thank you, George.
Thank you,
That
Jealous.
is
I
amazing
hope that you're
case.
a little bit refreshed, just
Yeah.
as a little bit to see some coronaries in practice.
Yeah.
And we can
But
go
I
back
have a
to
philosophical question. We all know that CTOs is a subtype of lesion is severely undertreated. And this type of lesions, especially this kind of CTOs, can be done really by a few number of people. How do you think we're going to approach this? Let's say this patient has the opportunity for operation, AOD, it is indicated. But for example, for right coronaries, which are big enough, the patients are symptomatic, and we know that CTOs in 50% located into the right coronary, how we can make them more accessible to these patients to such a successful treatment?
First of all, I think you made a very important statement about what might be the best treatment options for these patients. And surgery always remains an option, something that we have to document. The second thing is that the indication has to be very strict, and there are criteria about the symptoms, about the myocardial mass that is perfused by these coronaries, the viability, and all these kind of questions. So to come to the essence of your question, I do believe that as we speak of today, and for a field that it is around anymore 10 years old, or 2005 to 25, 20 years old, technical and wire evolution has been dramatic, but also the community of interventional cardiologists that they're skilled enough to tackle the majority of the CTOs is existing as a mass. One thing that someone should not forget, and this is the epitome of what you're asking, is that not all CTOs are the same. So if you have physicians, and I think that in experienced institutions like as yours, that they can tackle up to the JCTO score 3 with a success rate of more than 90%, because that's a prerequisite. When you put a patient on the table, you need to know that you have the skill set and you have the materials to achieve success. Then I do believe that the rest of the cases, which do not represent more than 15 to 20%, they can be addressed by inviting operators, by centers of excellence at the highest level, and that's how the community has to be provided. The only concern that I believe that it is existing anymore is that this procedure is around 40% more expensive than a normal procedure, and it has a complication rate of around 3 to 5% in the complex cases, that they are adding another 50% on the cost. So when you have a procedure that it is complicated, then you expect to have double the price on the cost of what you expect in a normal PCI. And all of these considerations, they have to be taken into account in a center organization, which in my view is even more important than a personal development of one single physician to perform and achieve these success rates. But there is a lot of work has been done, and I believe that you have been part of this journey, and you know that very well, and many skillful operators around the field.
Thanks, George.
Thank you
George,
very much.
that was really a great
As
presentation.
always, my great pleasure
Thank
to
you.
be here.
Thank you.